After 1 minute, yes.
Good evening, everyone, and welcome to today's session. I'll be your presenter today. My name is Mora Lorin. I'm a clinical nutritionist, and I will be presenting about chronic kidney failure. So I'm just going to start right at it now that we've lost a few minutes. And so chronic kidney failure is the progressive deterioration of kidney function over time. And this is based on a gradual decline in GFR and creatinine clearance. Frequently happens that it leads to an irreversible kidney damage, which is end-stage renal disease, which we will look at later in the presentation. It can also be defined as kidney damage for more or equal to 3 months, as defined by the structural or functional abnormalities of the kidney with or without decrease in the GFR. So, before we go any further, I would like to go through the stages of chronic kidney disease so that we know where this starts and how it progresses through to the end stage kidney disease. So the first stage of CKD, we start at stage 1, which is basically kidney damage with normal kidney function with a GFR of 90 or higher. That is stage 1. Stage 2 is kidney damage with mild loss of kidney function, having a GFR from 89 to around 60. We have our stage 3 has been divided into two. There is stage 3A and 3B. So 3A is mild to moderate loss of renal function, and that's 59 to 45 for the GFR. And we go to stage 3B, which is moderate to severe loss of kidney function, which has 44 to 30 of the GFR. We have stage 4, which is severe loss of kidney function, which has the GFR being from 29 to 15. And lastly, stage 5, which is end stage kidney failure with a GFR of less than 15. Now that we've gone through the stages of kidney failure and we've defined what it is, I would want us to go through the functions of the kidney so that we can understand what really happens when our kidneys fail, what stops working in the body, and how does this affect the different systems that the body runs on a daily. So the functions of the body include removal of waste products. The kidneys basically wash your blood. They remove excess fluids. They balance electrolytes. They also stimulate red blood production through the synthesis of erythropoietin. They also regulate your blood pressure through the RAS system, which we are going to look at later. Maintenance of healthy bones, and which encompasses basically metabolism, synthesis of vitamin D, and the sorts. So I'm going to get right to the pathogenesis of chronic kidney disease. And how does this happen? How do we get our healthy kidneys coming to basically having failure or reduced function? So the basic unit of the kidney is a nephron. A nephron is what does all the filtration and major major functions of the kidney. So we have a couple of good nephrons, millions to say, and once half of the total nephrons are lost, CKD progresses similarly, regardless of the etiology. And initial hyperfiltration activates RAS and causes proteinuria. Okay, let me go back a little. So we have a couple of nephrons. We have a couple of nephrons. So when they go down, let's say it's because of pathological issue, maybe it's diabetes, hypertension, and the non-communicable diseases. Sorry, name them. When the nephron number goes down, the remaining ones are trying to adapt to filtration. So they increase how they are filtering the wastes, the water, and everything. which is called adaptive hyperfiltration at the glomerulus. And this, as it continues to hyperfiltrate, glomerular permeability goes high. So this means we are almost starting to filter everything, even the ones that we don't need to filter. Things like proteins, red blood cells, and whatnot. So when the glomerular permeability goes high, so does the renal, the RAS system. The RAS system contains the RAS angiotensin aldosterone system, which is responsible for bringing back the blood pressures to normal. So when we've gotten at increased glomerular permeability and we are losing proteins, and the body starts breaking down the lipids, yeah, now we are coming to about, we are getting complications already, complications such as malnutrition. Yeah, and with the time this goes on and on until we come to get tubular interstitial fibrosis. Yeah, so our nephron starts dying a little, the cells of the nephron start dying, and that's how we get to a reduced GFR, a reduced urine output, and systematic complications. I don't know if you are following, but if you have questions about it, questions can come at the end of the presentation. I highly welcome them. So, I'm sorry about that. Although CKD is caused by a variety of underlying pathologies, as it progresses, a consistent pathological syndrome emerges. And this is characterized by hypertension, as I said earlier, cardiovascular disease, anemia, bone disorders, metabolic acidosis, among others. So all these are basically the complications of kidney disease as it progresses. So I would want to look at one of the major causes of CKD. We have hypertension and we have diabetes being the major of them all, but there are a couple. My colleague last week looked at AKI and the factors that bring about the disease, talked about pre-renal factors, factors like hypoventilation, factors like hypotension and whatnot, having not enough blood supply to the kidneys that affects the function of the kidneys, and intrarenal and postrenal. So they are in it, but for now we are just going to look at hypertension and diabetes. So when CKD progresses, there are glomerular and vascular changes. So elevated systemic blood pressures cause a hypertrophic response, leading to initial thickening of the large and the small vasculature. And the mechanisms are compensatory at first, but later they lead to glomerular damage. Yeah, and things about global sclerosis, which brings about ischemic injury to the nephrons. And again, we are back to tubular necrosis. Yeah, diabetes, hypoglycemia in the body also has direct damage to the kidneys. It could clog the nephrons and bring about systematic inflammation that would increase the glomerular permeability. And we are back again to what we talked about in our pathogenesis of the disease. So those are some of the risk factors: diabetes, hypertension. We also have obesity. We have metabolic syndrome. We have acute kidney injury. We have issues like malignancy. For example, a malignancy of the prostate. Enlarging of the prostate could cause an obstruction, which could bring about issues of infections. And again, we are hurting the nephrons. We come back again to tubular necrosis and a reduced number of nephrons and reduced urine output. And so the kidneys are damaged. Yeah, so those are the risk factors of kidney failure. I said malignancy, there is family history, there is kidney stones and infections such as hepatitis C and HIV. We have nephrotoxic drugs. There are some HIV drugs, even diabetes medications that in one way or another affect the kidneys. We also have autoimmune diseases such as lupus, when the body starts attacking itself and destroying organs and the sorts. So I'm going to look at the clinical manifestation of chronic kidney disease. Yeah. So the kidneys have failed. How is this going to affect the body? How do we get to see it? How do we recognize it? And which systems of the body does it temper with? I'm going to start with the hematologic manifestation, and my first point is anemia. So, as we said earlier, one of the major functions of the kidneys is production of erythropoietin, which plays a major role in production of the red blood cells. So these in one way or another affect the body so much, including the heart, whereby low levels of red blood cells strain the heart so much. So the heart will try to compensate, yeah, and try to pump as much as it can, which can lead to left ventricular hypertrophy, or in one way can lead to vascular damage in the body. And that again has destroyed our vessels, which can bring about hypertension. So you see, these factors just go round and round. That's why the management has to be quite thorough, because one complication leads to another and another and another. So for hematologic manifestations, we have anemia, as I've said. There are also other causes of anemia in CKD, apart from the reduced function of the kidney, which reduces erythropoietin production. The frequent hemodialysis sessions is one of the other points that causes anemia in CKD. We have frequent lab samples. We will go through the management and you will see that these patients of ours need monitoring and evaluation that is very consistent and as many times as you can. So these frequent lab samples, you take a lot of blood, the HB goes down a little, and those complications. We have use of gastric acid inhibitors and phosphate binders, and also inflammation, which affects iron absorption. That is for anemia. We have other hematological disturbances, i.e. infections, because of the changes in leukocyte function and the altered immune response with the diminished inflammatory response and the sorts. We also have bleeding tendencies, and bleeding tendencies come by about because of the defect in platelet function. So that is how CKD manifests in the hematological system. We are going to the urinary system. In the urinary system, we have polyuria, which results from the inability of kidneys to concentrate urine. We also have oliguria. This occurs as renal failure worsens, and anuria, which has an output of less than 100 ml per day. Remember, the body per day is supposed to give at least 500 ml per day, and when you're not excreting as much water, this means a lot of water is being held back into the system. Yeah, this means our kidneys are not working, and our function of water reabsorption, excretion, and the balance of water and electrolytes has been tampered with. So My next system, I will look at the cardiovascular system, although I think I've already talked about it. My first point will be hypertension. As we did see in the pathogenesis, we saw how kidney damage induces systematic raise in blood pressure, and how this occurs so oftenly that it brings about damage to the vascular system. The vascular system is the one in charge of hypertension. It's the one that will it's the one that sets the pace together with organs such as the heart and the kidney. So CKD can lead to hypertension or the other way round. We also have heart failure. With heart failure, it can go both ways. Heart failure can lead to CKD, and CKD can lead to heart failure, especially the point I talked about with the left ventricular hypertrophy, whereby the heart tries to compensate, to give more, to push more, but then ends up getting damaged. And then we have arrhythmias which are caused by the electrolyte imbalances that are brought by the kidney's failure to, well, balance electrolytes. My next system is the respiratory system. Uh, with fluid overload in the body, there is a lot of water moving through the body, and the compartments are not in the way they are supposed to be. So we end up having complications such as pleural effusion. And remember, the kidneys, now that they are failing, we're not having waste removal as it's supposed to be. So we are having uremic wastes going around the body, which can lead to a uremic lung, which predisposes the body to infections in the lung and all that. We also have dyspnea, which is the shortness of breath, having water in your lungs, and all that affects ventilation and majorly the vascular system. So we go to the next system, which is gastrointestinal system. The gastrointestinal system is affected majorly. So again, our kidneys are not working. We have urea in the body. We have all those waste products. We have water retention. We have a lot going on, and with a lot of waste in the body, inflammation goes very high. With inflammation, there are mucosal alteration in the GIT, which brings about a lot of GI bleeding. Sorry, there is nausea and vomiting. There is basically mucosal alterations, and these affect the GIT in the fact that there will be impaired gastric emptying, bringing about constipation and the whatnot. There is impaired intestinal motility, uh, yeah, and then disturbances of digestive and absorptive function. There is also alteration in the intestinal bacterial flora, which puts the GI integrity at a very vulnerable place. And we also have delayed fat absorption, among others. Um, the CKD also tampers with the neurological system, having altered mental stability. There is comas and dialysis, encephalopathy. We have peripheral neuropathy, muscle twitching. Most of these problems come about from electrolyte imbalances. Yeah, so electrolyte imbalances can have a major effect on the body, having issues like arrhythmias and the sorts. We also have hypernatremia, giving irritability and restlessness, altered mental level of consciousness. Sorry. We also have hyperkalemia bringing about muscle weakness, though that's not in the neurological system. We have hyperglycemia giving a neurological issue of mental confusion and the list. So does hypocalcemia. So as renal failure progresses, electrolyte imbalances increase, there is metabolic acidosis, there is increased nitrogenous wastes, there is demyelination of the nerve fibers, which majorly, as we've looked before, affects the neurological system in a very major way. And something I've forgotten, sorry, the musculoskeletal system. We also did talk about vitamin D3 as vitamin D3 synthesis as one of the functions of the kidneys. And well, if the kidneys are not working, so we won't have vitamin D3. Yeah, and in that we won't get enough calcium for our bones and for the strength of bones and that, and this weakens the bones and increases the risk of fractures. Well, my colleague will be looking at that on another day. Another system I haven't talked about is the integumentary system. The integumentary system mostly deals with how uremia presents itself to show on the skin, like a uremic frost, which is basically just deposits of urea found on the skin. We have dry, pale skin. We have thin nails and dry, brittle hair. We have yellow gray discoloration of the skin due to absorption of urinary pigments, and pruritus, which is basically the uncomfortable irritating sensation that creates the urge to scratch. So CKD also has effects on the reproductive changes, and for women we have menstrual irregularities. CKD takes part in endocrine functions, which got a lot to do with hormones. So it's bound to make reproductive changes, i.e., menstrual irregularities. We have infertility to some extent and decreased libido. For men, we have impotence, we have testicular atrophy, we have decreased libido and oligospermia, which is basically reduction of the sperm count goes low. And also the endocrine changes of the kidney. We have hypothyroidism. We have increased production of prolactin, which is majorly because of drug therapy. We have immunologic changes, which comes about from the depression of human antibody formation and the decreased function of leukocytes. We also have delayed sensitivity. So apart from all those systems, we also have psychological changes. Psychological changes covers behavioral changes, because a lot changes in accordance to the stage of CKD. One will need to get comprehensive therapy, could be dialysis and the sorts, and this tempers a lot with their daily lives. Yeah, the kids can't go play out like other kids, and all of that. There is decreased ability to concentrate. There is anxiety, depression, and many other withdrawals. So the complications of all of these, how CKD complicates the body and how it manifests in general. We have fluid retention. We have hyperkalemia. We have malnutrition. We did look at how the body how the nephron begins to filter off proteins, and we are losing a lot by that, so malnutrition comes in. We have cardiovascular disease, which comes about by the destruction of the vascular system. We have weak bones, as I said earlier. We have damage to the central nervous system because the electrolytes, as I said again, play a very big part in the central nervous system. So when the kidneys are not working as it's supposed to be, then we have damage to the central nervous system. We also have decreased immune response, and over time we will get irreversible damage to the kidneys, which now the patient has to be very dependent on machines or nutrition therapy or medication, whichever it could be. Um, so we have diagnostic studies. How do you get to know that your patient is what gives you the yes arrows of my patient could be having CKD? What do you examine? So there is history and physical examination. You can literally see fluid retention. When you're examining the patient, you start from the head, from the thin hair, the bristle nails and everything. Maybe there is facial puffiness that you can see. These are some of the signs that will show you that your patient's kidneys might not be working well. So there is also history of the patient. Is there history of such? Is there history of comorbidities that might have been leading to chronic kidney disease? Yeah. And then there, as we all know, anthropometrics, yeah, such that it will help greatly in monitoring and even when managing the patient, you start giving your kilocalories from where the patient is at. Yeah. And then we have routine lab measurements. We have the blood urea nitrogen, we have the serum creatinine, we have electrolytes and the hematocrit and HB levels. We have urine analysis and culture and the LFTs to importantly check on the albumin and total protein, which will be a very good indicator of the nutritional status of your patient. We also have vitals such as blood pressure and blood sugars. As we already said, hypertension and diabetes are the major causes of CKD. And we also have renal ultrasound, the scan, the CT scan, and renal biopsy. All these will show if there is any necrosis with your kidney, what is happening, is it any smaller, is it, any changes, so that you can make a good diagnosis. So we have factors to consider when managing your CKD patient. One, we have the stage of the disease. How you manage your stage 1 CKD is very different from how you will manage your stage 4 CKD. And then we have the assessment. Management is very individual. There is no fixed rates of administering anything. It's very individualized. So you will look at the anthropometrics. I've already said, biochemical results, evidence-based physical examinations. We have dietary assessments, because you have to know the preference of your patient, what they have taken, what they're used to taking before you even think about preparing a meal plan. The functionality status. Is your patient home alone? Are they ambulating? Such that you can find out the best way to manage them. The socioeconomic factors. Can your patient afford the high biological value protein you're giving? And so on and so forth. So we have functions, or let's say goals rather, for renal function, for renal, sorry, goals of CKD management. And this is, you'll want to control the disease process and its complications. you'd want to control blood pressures or any other available comorbidities, and basically improving the blood chemistry. And this we will do by dialysis or transplant. There is medication, there is nutrition therapy, and so on and so forth. So we also have the pharmacological management bit of it. Well, this will be tackled by a colleague of mine, but I'm just going to state them. We have antihypertensives because we said CKD either brings about hypertension or the other way around. And we also have diuretics with impaired excreting of water. We have fluid retention, which will be solved by diuretics. We also have antacids, cardiovascular agents, antacids because we have a lot of metabolic acidosis. There is a lot of waste roaming in the body, and the kidneys ain't keeping check the acid base balance. So antacids, we have anti-seizure agents, and erythropoietin for the anemia, could be IV iron supplementation, or the IFOS, the iron oral supplementation, the folic acid, and so on and so forth. So I'm going to tackle nutrition. And the goals of the nutrition therapy is a slow disease progression. We manage complications and basically improve nutrition status. You see, with an improved nutrition status, the body is at a better state to fight for itself. And so because we have a lot of depressed immunity, and if you can put that at a better state, then the complications will be a little lesser. So for stage 1 and 2, our energy requirements will be at 30 to 35 kilocalories per kg per day, which is basically guided by the age and gender, level of physical activity, nutritional status, among others. So 30 to 35 kilocalories per kg. We have protein requirements of 1.3 to 2 grams per kg per day. And we are to limit simple carbohydrates and emphasize on complex carbohydrates. We are to limit sodium individually as assessed, preferably from 2 to 3 grams per day, and potassium of 2 to 4 grams per day, which is also managed individually. We have calcium of 1200 to 1500 milligrams per day, and the fluid maintenance is done per patient. So if it's less than 1 liter, you can add 500 ml as the intake, the output plus 500 ml. I'm going to look at stage 3 and 4 of our management. The energy requirements remain at 30 to 35 kilocalories per kg per day. And also this is individualized because you could be managing an overweight patient and you have to adjust their ideal body weight. Their protein requirements should be at normal, with sodium at 2 to 3 grams per day. We have our phosphorus at 800 to 1000 milligrams per day, and calcium of 1.2 to 1.5 per day. Again, for the fluid, it's the output plus 500 ml if less than a liter. If more, do not restrict. We have patients that could be having CKD but on hemodialysis, so we have management for that too. We have our energy requirements remaining the same at 30 to 35 kilocalories per day, and being at 1.2, preferably the very high biological value protein. We have the sodium of 2 grams, the potassium of 800 to 1000 milligrams per day, phosphorus of the same, and the supplementation of complex vitamins. This is because water-soluble vitamins tend to tend to get lost a lot during hemodialysis, and they are very important with the functioning, the normal body functions. So supplementation is really good, including the vitamin D, because if the kidney function is reduced and one of its functions is metabolism of vitamin D3, then we will need to supplement. So among the management is nutrition counseling and education on food preparing methods. And with this, you will look at bleaching of vegetables to lessen dietary potassium. We have the soaking of legumes this is to reduce anti-nutrients and basically regulate the potassium and phosphorus. We are also to restrict potassium rich foods, i.e., oranges, the bananas, the avocados, and whatnot. This is individualized. You manage your patient as the lab values. It's supposed to be, it's evidence based. So yeah, you can restrict your root tubers because of the high mineral content of phosphorus and potassium and all that. We also have lifestyle changes and monitoring of vitals and sugars. Well, that is my presentation today. I don't know if you guys have any questions for me. Thank you for listening in. Good evening. Anything you guys would want to add for me? Maybe there's something I've forgotten or wasn't clear enough.
Thank you so much, Lauren. The topic was very clear. You have added a lot from the previous topic, AKI. I think they go hand in hand. We have also talked about the issues of the nephrotic drugs, which has clearly come very well. Thank you so much for the addition.
Noted, you're welcome. Effie, Priscilla, Damaris, Eve, anything I have forgotten that you would want me to clarify for our audience?
Not really much. I guess you have captured well the topic of CKD, covering it into different systems. That was a nice job. Keep up.
Hi everyone, this is Effie. So,
Thank you.
so today is day 5 of our live broadcast, and our presentation was done with Maureen Laura. Thank you so much, Laureen. You did so well. For anyone who came in late, today's topic was CKD in CKD, yes, and Lorraine tackled some of the topics like the staging of CKD, the pathogenesis, the causes, the effects of CKD, the goals of management, and nutrition therapy in all. So thank you so much for the presentation. And whoever didn't listen to it, you can after this podcast, you can listen to it later on to in our YouTube channel or Facebook account. Thank you.
Okay, I can see in the chat box there is a question. It says, you talked about antacids helping in acid base balance. How will it help manage metabolic acidosis when it mainly acts to reduce acidity in the gut?
Has anyone heard what she's saying? Because I cannot hear her. Hello? Hello?
Hello.
Can hear you.
Yeah.
Can't you hear me? Who can help in answering that question?
I think we lost it a little bit.
Am I audible enough?
Yes.
All right. Nema, what do you think? What do you think is the response to that question, kindly?
The question is about how will antacid in acid-base plants, how will it help metabolic acid when it reacts to reduce acidity in the gut? As for now, I don't have an evidential answer, but we know that kidney disease has also its gut. So that question in it, but I need to check further. Sorry, my mic somehow goes.
Yeah,
But
I hope everybody has heard you. I cannot hear you quite well. I guess you have disconnected with Rorin. I guess she has an issue with her network. Anybody else with any input? Maybe you can add.
I don't know why my going on and because my net is full, but
Milan, you can help out Rorin. I guess she's in the backstage. All right.
Thanks. What was the question again?
We're being asked like how will antacids help to manage metabolic acidosis when it mainly acts to reduce the acidity in the gut.
You see, when metabolic acidosis happens in the body, it just doesn't happen in one point. It happens in the GIT, and basically, everywhere in the body. So for better digestion and to preserve the integrity of the GIT, antacids are given to bring that high levels of acid down, so that maybe some food nutrients are not denatured and the sort. I don't know if I'm making sense or someone has another idea. What do you think?
Personally, I guess that's that's a good explanation. Back to you, Mora. We can finish for us this presentation.
Milan, I think it's over to you now.
Okay. I think we thank you, Lorraine, for a wonderful presentation this evening. I want you to look into that question tomorrow when we have the next speaker discussing. We want you to be able to discuss with us that question. This will take a few minutes after tomorrow's presentation. You'll basically have to come back to us with this discussion for a short time, say in 10 minutes. You should be able to give us a better view about that question. And I think that will be able to help the viewers and those who are interested in that subject to be able to better understand that concept. So thank you and have a wonderful evening.